I thought I'd pay homage to my mentor, Prof.R.Krishnan, to whom I'm beholden for various things. I'm going to do things slightly differently. I'm going to tell you the logic behind the treatment before going on to the treatment itself. So, Udayavasan, you can stop me at any point. It doesn't really matter. Because I'm more interested in the evolution of the disease and the management rather than its component parts, which can be read up anyway. Well, the definition of peptic ulcer is a break in the lining of either the lower esophagus, the stomach, or the duodenum. And the words dyspepsia are used for non-specifically. And if there is heartburn, you use the word gastroesophageal reflux disease. And if they find nothing, they call it functional dyspepsia. You have to know the past before you go on to the future, whether it is Confucius or Carl Sagan. But what they said is looking back gives us a lot of wisdom. From time immemorial, there were two views, two opposing points of view. One was the bacterial hypothesis as early as 1868. Kussmaul, of the breathing fame, used bismuth to heal ulcers. Bacterial colonies were then detected, and in 1906, a person called Turk fed dogs with E. coli. But the predominant opinion was that without acid there was no ulcer, and stalwarts in surgery like Schwartz and Moynihan felt they were dominant, and therefore everything else became second place. Antacids were used as early as 1915. But this is a history of wrong turns and lost opportunities. Lots of people had apples falling on their head, but only one discovered gravity, they say. There are three names I'd like you to bring to your notice. One is Stone Friedberg. He was basically a cardiologist who identified the H. pylori in gastric biopsies. But then his work, and he found spirochetes on autopsies. He lived on to the age of 101, and in fact saw his work taken up by somebody else and the Nobel Prize disappearing under his very eyes. In fact, his work was so great, but his research guide said, "This is rubbish, don't carry on," and asked him to stop. And later, Marshall said that if only Friedberg had carried on, he would have got the Nobel Prize as early as 1950. That acid eating away the mucosa was responsible for ulcers was the current thinking at that time. But simultaneously, there were people who used penicillin who found it effective. The other names that I'd like you to remember are Charles Lieber and Andrew Lefebvre, and who sent a paper to say that gastric urea and ammonia conversion helped in treating the disease. Nobody took them seriously. Sorry. But this is the man who was recognized for a long time. This is a Greek general practitioner who had peptic ulcer himself. He treated himself with antibiotics. He got a patent in Greece for the antibiotic treatment of peptic ulcer disease. But when he sent a paper to the Greece Medico-Surgical Society, they said, "Rubbish, we won't have you." And his manuscript was rejected by the JAMA. Incidentally, much of the information that I give you now is from a latest article in JAMA itself, who gives us the history of the whole thing and the latest in treatment. And in fact, they went to the extent of fining him money for making such an observation. So like happened to Galileo, he was asked to recant that the earth was not, when he said that the earth is not the center of the universe, they made him stand up and say, "No, it is the center of the universe." And when he came out of the meeting, he said, and yet it moves. It's a very famous story. It took 19 years after Lysistrata's death for the Lancet to publish 2 articles to say that his name was never recognized and that he should be given credit. As early as 1960, they found Campylobacter-like organisms in stomachs, cats, dogs, gerbils, so on. And in 1975, Steer and Colin, I was working in Southampton at the time, and Colin Jones was a gastroenterologist. He had worked on carbenoxolone, but eventually he gave it up and said, look, it's only a contaminant and there's no future in that sort of research. And that was published in Gut in 1975. Things changed. In 1975, Robin Warren was a pathologist who found curved bacteria in gastric biopsies. It's interesting that an asteroid is now named after him. Barry Marshall was a young resident who joined the Royal Perth Hospital for specialist training under him. And he noted that lots of people had erythema of the stomach and curved bacteria on the biopsy. He tried treating them, nothing happened, and as happens to all of us, the poor woman was told that she needed psychiatric help and was given antidepressant medication, and nothing happened, of course. So Robin Warren got interested when Marshall showed him slides of these curved bacteria. Initially, they were thought to be Campylobacter. And they dismissed it as artifact because at that time everyone felt that gastritis and ulcers was from too much spicy food and alcohol. And but as things happen, as I suppose happened in the case of penicillin, after prolonged culture over a long weekend in 1962, the organisms were grown, and later the same year in 1982, EM pictures, electron microscopic pictures of the organism were produced. In February 83, what happened is that Marshall's abstract was rejected by the Australian Gastroenterological Society. They thought, but simultaneously they accepted it in Brussels. In 1984, he had produced a paper which Lancet published to say that 77% of gastric ulcers and 100% of duodenal ulcers indeed had bacteria in biopsy. Since there was no animal model, Marshall decided to experiment himself. They did a baseline endoscopy on him. He drank a culture, and within 3 days he had symptoms, nausea and hydrochlorhydria. He started being sick on day 8, and endoscopy was done, which showed gastritis and positive curved bacteria. Now, after the 3rd endoscopy, he started himself on bismuth and an antibiotic, and he recovered promptly, proving cause postulates. In 1989, ribosomal sequencing showed that this was not Campylobacter, which was the name it was given till then, and they called it Helicobacter pylori. And this is the silver stain which fetched Marshall and Warren the Nobel Prize. Till then, all sorts of people had tried other stains. The silver stain made a difference. Why I am saying all this is that there are youngsters among you here who may be dissuaded by older people like us from carrying on a piece of research, but persist and you might get the Nobel Prize, who knows. So by 1994, lymphomas and gastric ulcers were found to be related, complete sequencing and new virulence factors were discovered by them. And in 2005, the Nobel Prize came the way of Marshall and Warren. This is the chap who creates all the trouble. It's a curved organism, lots of flagella. In fact, the name, I'm not sure. I had a picture of the organism whirring with like a helicopter, but I can't get that on the net now. And these flagellae give the organism a lot of mobility, and it's a very ubiquitous organism. It's found in nearly half the population of the world. And it's very unique in that no organism can survive in a pH of less than 2 in the acid other than this particular organism. What it does is to burrow into the gastric mucosa, and it sort of secludes itself in a niche. The pH is less than 2 in the stomach, but in that burrow it's 5 to 6 and it survives. So it neutralizes the acid by secreting urease, which is broken down, as you will see, into bicarbonate and ammonia. But one of the remarkable things that happened was an article in Gut of 2012 by the professor of gastroenterology in Glasgow, where this is the normal gastric mucosa, and these crypts, which are very tight junction. And there is a mucus lining which is protective, and all the these various prostaglandins and various other chemicals are present which protect the gastric mucosa. And this is the invader, which has various defenses and various attacking, it's a great attacker, and what it happens is it burrows into the gastric mucosa. That looks, this picture doesn't come out very clear, but it looks almost like a Scud missile going and landing in the stomach. This is the Nobel Prize picture, that the gastric mucosa is maximally affected in the antrum. And the antral gastritis interferes with regulatory pathways for acid secretion. It leaks through these hitherto tight junctions. There's increased acid leading to development of duodenal acid. I don't answer it. Another set of people develop atrophic gastritis, and that leads on to gastric cancer. H. pylori thrives as a monoculture and makes the host have a cellular and immune response at the site of infection. The cells die and provide the nutrition for the organism to grow. So it's a self-replicating sort of cycle. And during the entire host lifespan, colonization continues. Spread is fecal oral or oral oral. We know now a lot of things about H. pylori, that there is a cytotoxin associated gene. A good number of H. pylori have this gene positive, and that lives in an island which is called the CAGA pathogenic island. Details and what is important is that those which are positive for CAGA lead to oncogenesis, and those with CAGA have an increased risk of gastric cancer, unlike the negative ones. So in this, the WHO has classified H. pylori as a class 1 carcinogen, and it's the only bacterium of that description. It's associated with BALT, mucosal associated lymphoid tissue lymphomas, and adenocarcinoma, and this has been proven by experiments on Mongolian gerbils. Gerbils are kind of rodents. Now what happens is that the H. pylori must go and adhere to the cell, and the gastric epithelium is something that renews every 2 weeks, and to initiate the changes, the carcinogenesis, the H. pylori must initiate it, but not for established cancer. Once its deed is done, the gastric cancer is the one that progresses. It's a sort of hit and run system. So I'll go briefly through symptoms and signs. For this reason, there are various risk factors. The Helicobacter taking prime place, and the NSAIDs. Some of it is idiopathic. Cigarette smoking is a known hazard, and psychological stress, they say, but not alcohol or coffee. So the tipplers in this group can proceed safely, I suppose. Various other drugs we will not go into are all causative factors, big list. But what is extremely important, I wanted to spend some time on this slide, and the reason is that time and again, anyone with abdominal pain is labeled as having a duodenal ulcer or a gastric ulcer. We've had this innumerable times. Please remember that we learned our anatomy long time ago, and it's about time we revised it. There's a foregut, the midgut, and the hindgut. The duodenum is a foregut structure, and therefore pain will always be in the upper abdomen. I've had this time and again of people. In fact, a surgeon referred me a patient 7 to 7 years ago for abdominal pain, and the poor woman was wasting away. She had occasional episodes of fever, and what she had, if you just take a history, a lady had pain around the umbilicus, which is mid-gut pain. And it turned out that she had tuberculosis of the intestine, and she got considerably better as of several years later. There was another man, very senior police officer, recently admitted, had multiple cardiological problems, including a defibrillator put in. And what happened is he had abdominal pain. Somebody had done an upper GI endoscopy, antral erosion zone found. CT scan was done, nothing was discovered. And then what happened is the story was that every time he had the pain, it was periumbilical. And periumbilical pain is never gastric or duodenal, because that's not where it originates from. And what he had was subacute intestinal obstruction. And once the surgery was done, he was much, much better. I just want to point out that all you have to do is to sit with the patient and listen to the story, and periumbilical pain is always, always midgut, just as suprapubic or sacral pain is hindgut pain. So please remember that, the juniors in this group. And the other thing is the timing, the pain food. Immediately after the pain is gastric ulcer. A couple of hours later, you're thinking of either mesenteric ischemia or duodenal ulcer. Of course, the site of the pain will be different between mesenteric ischemia and duodenal ulcer. Nocturnal pain, where maximal acid secretion. And periodicity is not the same as food pain. Periodicity is whether you treat or not, there are symptom-free intervals of 4 to 6 weeks, and the pain comes, and that is periodicity. In our day, we were told that periodicity meant gastric ulcer. Nodes, cervical nodes, and bowel sounds, don't forget. These are the complications we all know about. And the dictum is that all gastric ulcers are malignant, and all duodenal ulcers are benign, especially if they have raised edges or associated anorexia and cachexia. So that is the difference between the old dicta still holds. How do you proceed? You do an endoscopy versus barium studies. In our day, it was only barium. Endoscopy was never discovered. Udayavaskar was in the gastroenterology department. We didn't have a gastroscope. Or at least there was one in surgery just kept locked up long ago. That's all we know. And the advantage of endoscopy is that you can see and take biopsies. And there is now the rapid urease test, which converts urea to ammonia, which you can pick up on a little card test. This is the esophageal ulcer, and that is what you see on endoscopy. It makes a world of difference, especially when you get visualized. And that's a Mallory stare. Small erosions, multiple erosions, which you can make out on endoscopy. And the good old days, this is all that you could do. These are curtsy process, occasional. A little spot of barium with edema around it was a telltale sign of, and this is with no edema. Those are the only signs that we had. And this is an interesting picture he gave me of a little hair, and that is because of an intramedullary fistula. These are things I suppose now radiologists make out on CT scan. And you can see the barium. It doesn't come out very clearly. All this is this is the way. You see the barium which has got into the biliary tree. And you have the fistula, which are all complications. And every surgical list could be so many GJs, so many vagotomies, and so on, partial vagotomy, special kinds of vagotomy. But now the test for pylori are the urea breath test, which is a specificity of 100%. We don't do that. As far as I know, we don't do this in this part of the world. Whether they do it in the alternate state or something, I really don't know. You give a labeled urea substance and check the amount of carbon dioxide that is excreted in the breath. Sensitivity is supposed to be 100%. You don't have to do endoscopy and a rapid urease test. The other stool antigen test, lesser degrees of specificity and sensitivity, and serology. Old ones and new ones have a lesser degree of. So having done with the logic behind, we'll go into the treatment itself. Well, as always, this used to be the advice: stop smoking, avoid stress, spicy food and alcohol. Avoid stress is easily said. Aspirin, NSAID, steroids. Treat the acid. And in those, once upon a time, it used to be surgery in plenty. No special. Lots of lives have been destroyed by the milk diet and this and that and the other, which we used to advise our own patients. I'm sure many of them would have cursed us. And the medical therapy consists of either some way to decrease the secretion, either using H2 receptor antagonists or PPIs. Please remember that PPIs, they are good things, but long term could cause fractures, pulmonary infections, renal dysfunction, Clostridium difficile colitis, and enteric infection. None of these are unmixed blessings. The best thing is to keep off NSAIDs, but that's more easily said than done. And H2 receptor antagonists hardly anybody uses now. But there's a trend towards going back to it because of the risks of PPIs. But the cimetidine, which is the earliest one in our day, gynecomastia impotens, and it interferes with hepatic enzymes, it interferes with a lot of drugs. The current regimens, basically you're going back to bismuth and antibiotics. That's what you use, and reduce the acid. I suppose that's a good compromise between the two schools of thought. There's a great deal of antibiotic resistance to H. pylori. I asked the people around in microbiology whether they can do cultures. They don't do. They need special medium. It takes a lot of time, but it's not done as far as I know anywhere in this part of the world. And we have very little information about H. pylori because we can't culture it so easily. How many are resistant to what drugs is still a matter of concern. Maybe in the near future somebody will come up. Pill regimes simplify things, but they're expensive, and the availability and cost of certain drugs like say tetracycline and all means that each gastroenterologist treats differently. There's a heterogeneous prescribing. So there's no standardization among the gastroenterologists, and that's a cause for concern. The complexity of the H. pylori regime, the high pill burdens, and the frequent side effects means that patient adherence to therapy is very limited. So factors to be considered relate to the H. pylori, resistance patterns and so on. Host factors, previous antibiotic exposures and so on. The cost and the ease of administration make this a daunting disease. Basically, two types of therapies, triple and quadruple. You have two antibiotics and one PPI, you call it triple therapy. You've got two antibiotics and bismuth plus a PPI, you call it quadruple therapy. The antibiotics commonly used are amoxicillin 500 milligram into 2, that's 1 gram twice a day, clarithromycin 500 milligram twice a day, and any one PPI, and you call it a triple therapy, 1, 2, and 3. You add bismuth subsulfate 120 milligram into 2 twice daily, and you call it quadruple therapy. Now, there's a new boy in the block called vonoprazan, which is a potassium, what do you call it? Thank you. That's why we need younger people. This is the competition. Any one of them, please remember that. Any one of them would do. One is not superior to the other. And I'll tell you why I'm showing this slide. Clarithromycin or amoxicillin, and the alternative antibiotics used are metronidazole and levofloxacin. I put up a list of costs just to make you aware of what's happening. Metronidazole is the cheapest, please remember that. 1.7 per tablet per tablet. Amoxicillin, clarithromycin is very expensive, 46 rupees or so, and you need 2 of them. Levofloxacin is so. Colloidal bismuth, I was very surprised to find that in the American books, they said colloidal bismuth was cheap. If one tablet of this costs 29 rupees in this country, it can't be cheap in this country. Anyway, and you need 2 of them. All the PPIs are equally effective, and this is the cheapest. Omeprazole, which is 3.21. There is one particular company that specializes in making cheap drugs. I will not mention it in this group. But pantoprazole, which costs 12 rupees or so commonly, costs 4 rupees for them. So be aware. So there's a great variety in the market, and I think it is important that we realize that. Vonoprazan costs about 19 rupees for 20 milligram, and sucralfate is available as syrup. Carbidoxolone is not used now. And there are kits. These are the ones I picked up from baby. I have no special reason to promote these, but they contain clarithromycin and amoxicillin and esomeprazole, and the cost is about 230 per day. Please remember that, 1 kit per day. Pantocid HP, different company, same antibiotics, but has pantoprazole, and the cost is about the same, 280. The American College of Gastroenterology commissioned a practice guideline in 2024, and this is and they said that for those who have not received previous treatment, the preferred regimen would be bismuth cortical therapy. Bismuth cortical therapy, that's BQT. And they use a lot of rifabutin and a potassium competitive acid blocker, and the total treatment is for 14 days. That is the chart which I got from them. I'm sorry, it's not very clear. It's my eyes or the projection, I can't see too much. But basically it's the same what I told you earlier. And if they have already received H. pylori treatment, then rifabutin, amoxicillin plus rifabutin plus omeprazole is preferred. And there are salvage regimens which contain clarithromycin or levofloxacin. And this is the table which they have used. Basically, if you remember, so healing of ulcers better with PPIs. For duodenal ulcer, basically 20 milligram daily. What we normally give is to give 2 weeks of all the antibiotics and another 4 weeks of the PPI. But for gastric ulcers, you need more, give it for 8 weeks, and large ulcers also you give for 8 weeks. And the healing is pretty good for duodenal ulcers and for and vonoprazan. The only advantage is that it's better absorbed, and we don't have much. The gastroenterologists in our place are using it, but they are not very convinced that it's any better than the others. Levofloxacin, there's a good deal of resistance. So also with clarithromycin. You're paying such a lot for clarithromycin, and if that is a 31% resistance, I think you should be very, very careful using that. The combination is levofloxacin plus amoxicillin plus PPI, clarithromycin plus amoxicillin plus PPI. Adding bismuth, eradication rates are about 81%. Bismuth plus tetracycline plus metronidazole. Nobody uses tetracycline here, that's all I know. Maybe we will sooner rather than later. Adafabutrin is not available as vonoprazan. Triple therapy means vonoprazan, amoxicillin, clarithromycin. Dual therapy means vonoprazan and amoxicillin. Thank you very much.